Dear colleagues, I am Bruno Lourenco Costa from Portugal. It is an honor to join this scientific event and to share my work with you. I have no conflicts of interest to declare, and I will talk about clinical issues, very boring. I will talk about two surgical complications, two vascular complications from neurosurgery. From neurosurgery, and my talk will be divided in two parts. In these two papers, we described two vascular events: symptomatic retrograde arterial thrombosis after a microsurgical resection of a cerebral arteriovenous malformation, and cerebral venous thrombosis. After spinal surgery and CSF drainage. And above all, we describe those entities almost unrecognized. We present our own cases, but above all, we provided some insights into their pathophysiology and proposed some strategies, some possible strategies to prevent it and to diagnose it earlier. Of course, these are rare vascular events, probably forgotten, extremely difficult to diagnose, and however highly lethal. Regarding symptomatic retrograde arterial thrombosis after microsurgical resection of AVM, Miyazaki, the first author that identified this vascular event, proposed some criteria for its definition, including total removal of the nidus without damage to the afferent arteries of the AVM, imaging evidence of filling defects with proximal progression, and those filling defects should have at least 3 centimeters. In this particular case, my case, a 70-year-old man after an uneventful resection of a temporoparietal Spetzler-Martin grade 3 AVM presented in the postoperative period a neurological decline, and as illustrated, thrombosis involving an afferent branch of the AVM. In this case, an MCA branch was present, starting in the resection cavity and presenting proximal progression until the MCA bifurcation. However, I must emphasize that some degree of retrograde thrombosis is a frequent finding in postoperative angiograms, and we proposed that the most defining feature of this condition should be that the thrombosis should involve important branches of the afferent artery and is associated with a symptomatic ischemic lesion. There are some risk factors have been pointed out for this condition: advanced age, large nidus, long and angiopathic afferent arteries, previous hemorrhage or vasospasm, surgical manipulation of afferent arteries, and intraoperative and postoperative hypotension, hyperventilation, and hemoconcentration. Regarding pathophysiology, retrograde arterial thrombosis happens due to sudden blood stasis when the nidus is resected. If the stasis happens in arteries severely damaged by high flow angiopathy and eventually vasospasm due to hemorrhage or previous manipulation, but the perfect storm happens when this happens in these phenomena take place in territories with poor congenital or pathologic collateral flow and impaired microcirculation. Due to the very reduced number of described cases, there are no prevention, there are no defined strategies to prevent or treat this condition. However, we believe that the proposed mechanism should provide some help. Regarding treatment, there are only some reports on the efficacy and safety of endovascular treatment and anticoagulation. In the second part of my talk, I will explore the relationship between another form of stroke, cerebrovenous thrombosis, and spinal surgery and CSF drainage. Of course, there are lots of risk factors consistently described for CVT. However, little attention has been given to CSF dynamics. During spinal surgery, as you of course know, during spinal surgery, meningeal injury is a relatively frequent complication, easily treated in the majority of cases. Sometimes we recognize it intraoperatively and repair it directly. In other cases, we don't recognize it intraoperatively or cannot repair it directly. In any case, the insertion of a CSF drainage system is a safe and effective option to treat a CSF leak with or without external fistula. However, we must realize that both iatrogenic meningeal injury and CSF drainage systems produce clinically relevant CSF hypovolemia, and this is the key point. In these cases, MRI is not often performed. However, in other diseases, MRI studies have shown clearly that CSF hypovolemia is related or causes relevant intracranial changes, including, as illustrated here, brain descent, cisternal and ventricular collapse, stretching and distortion of meninges, vessels, and nerves, subdural hematomas, fluid collections, diffuse dural hyperemia, and pituitary enlargement. And of particular importance, as predicted by Monroe Kelly model, some MRI and Doppler ultrasound studies have shown that the CSF, the reduction in the CSF volume in the neuroaxis is followed by a compensatory increase in the total blood volume in the cranial and spinal compartments. And an important part of that additional blood volume is accommodated in capacitance veins and to a lesser degree in dural sinuses. The same studies have shown, as predicted by hydrodynamic theory, that as the diameter of cerebral veins and dural sinuses increases, the velocity of flow of the venous blood decreases. We must also take into consideration that CSF reabsorption into the dural sinuses depends on CSF pressure. So, as reabsorption of CSF is diminished, the viscosity of venous blood increases. And finally, we must take into consideration the gravitational properties of CSF. When patients are recumbent, here, the CSF hypovolemia and blood hypervolemia are homogeneously distributed throughout the neuroaxis. However, when patients assume an orthostatic position, the CSF hypovolemia and the blood hypervolemia are suddenly increased in the intracranial compartment. Typically, this produces a characteristic clinical picture with headache, blurred vision, nausea, vomiting, and dizziness that worsens in the orthostatic position and improves in the recumbent position. However, at this particular point, we must realize that the vicious triad for cerebrovenous thrombosis is completely. Actually, the walls of the dural sinuses and cerebral veins are distorted, impairing laminar flow and endothelial antithrombotic properties. Venous blood flow is slow under physiologic conditions, and becomes critically reduced in this context. And additionally, as previously discussed, the viscosity of the venous blood is increased. And this is particularly dangerous in patients with prothrombotic conditions, and the trigger may be a simple shift from the recumbent position to the orthostatic position. We reviewed 23 papers, including all cases of cerebrovenous thrombosis possibly related to CSF hypovolemia, and we found that the majority of patients had genetic or acquired prothrombotic conditions. However, their history was negative for previous cerebrovascular events. So my recommendation, after injury to iatrogenic injury to the meninges during surgery or during CSF drainage system insertion, repair meninges if possible. CSF drainage insertion is optional, however, over drainage must be avoided. Keep patients in the horizontal or Trendelenburg position, and above all, replace CSF aggressively. After closure of the leak and removal of the drain, we must be sure that the patient do not develop signs of intracranial hypotension, and the shift to the orthostatic position should be very gradual. The benefit of chemoprophylaxis with heparin is not known. Finally, we must take into consideration that the diagnosis of CVT depends on a high degree of clinical suspicion, and these rules are good to orient our clinical practice. According to this prospective study, CVT still carries a mortality of 8% and a morbidity of 5%, a permanent neurological morbidity. So, for both forms of stroke related to neurosurgery, I would like to emphasize the criticality of clinical suspicion and early diagnosis. Thank you for your attention. I hope to see you in Portugal. This is Coimbra, my city, one of the oldest European universities, recently recognized as World Heritage, and it would be a pleasure to share ideas with you and keep in touch with you. Thank you.
Do you put lumbar drain in any of these cases?
Sorry?
Do you put lumbar drain in these cases? Lumbar drain. Continuous lumbar drain or intermittent lumbar drain, just to prevent the CSF leakage?
No, this work started when a patient, a colleague operated on, after spinal instrumentation, developed a CSF fistula, and a refractory CSF fistula, very difficult to treat. Several wound revisions, not easy. And at the end, he developed CVT. And young lady with CVT after spinal surgery is not.
Okay, these are these cases, or this case has been investigated for INR, that is
MRI.
INR, international.
Yes,
ratio.
we anticoagulated the young lady with the target ENR 2 to 3, okay. But empirically. Okay. No, there are not much information in this particular context.
Is it Joe Germanin or is it
my mail? Yes. Yes.
Is it from Portugal?
Yes.
All right. Okay. So you must be proud of him.
I have two questions. Jose Mourinho have a problem with because I don't understand. I like this man, but is it problem?
A smart man.
Smart man. Okay. So, and what can you say about the change of activity of cerebrospinal fluid production system of this system in such pathology after treatment, after your kind of treatment?
That patient, after anticoagulation, the patient recovered very well.
But you have some biochemical results of cerebrospinal fluid analysis.
When we faced this situation, this case was not. No one could understand why she developed CVT. So we started to work on this